from research to prevent blindness, Helen Keller Award from the American Glaucoma Society, and both the Senior Achievement Award and the Secretariat Award from the American Academy of Ophthalmology. He has published over 100 peer-reviewed articles. He has also developed a new glaucoma implant and OCT software to improve glaucoma diagnosis. We are very honored to have him today with us. Please join me in welcoming Professor Asrani.
Very good morning to all of you. Thank you very much for getting up early and showing up for the talk. I don't bite, so feel free to come in front and sit. Thank you very much for your very kind hospitality and for this invitation. I'd like to share with you, without any further delay, some of my pearls that I've learned regarding OCT in the use in glaucoma and multiple other diseases. So let's begin. The first page that you will see, by the way, let me first say a disclaimer. I have no financial relationship with Heidelberg Engineering, because I will be showing you the images from Heidelberg Engineering, and I will implore your CEO to get the Heidelberg Engineering incorporated into glaucoma, because that is a machine that allows me to look at things that no other machine allows me. So it is of real benefit, and we looked at all machines at Duke, and finally we ended up with Heidelberg. And so that's what I'm going to share with you today. One of the images that you get here in the nerve fiber layer analysis is the circle scan around the optic nerves. And it's laid out here like a ribbon compared to the normative database, and then an average of all the quadrants values is given. Most glaucoma doctors tend to want to do what I call kindergarten OCT. That is, looking at the colors, primary colors. Is it red? Is it green? Is it yellow? And that is not what we as glaucoma specialists should do. We should look at what is the least attractive area of the OCT scan, which is this, right here in the middle. The least attractive is where the gray and the black line intersect. Wherever there is a difference between the two lines is where there is glaucoma, because asymmetry is the hallmark of glaucoma. So wherever there is a difference between the right and the left eye is where you will see the abnormalities. Once you looked at this, you look at the compared to normative database. Then you look at the actual scan to make sure that the segmentation is correct. And then look at these scans, because these scans are also very valuable. Like you can see this nerve fiber layer defect right here. Now, as I said, the glaucoma is a diagnosis based on asymmetry. We always look for cup to disc asymmetry when we are diagnosing glaucoma. But it is for the first time that we have the ability to see both the optic nerves together in one image. Because, you know, I teach my fellows that the the nose is the biggest impediment to diagnosis of glaucoma. Why? Because once you look at the first optic nerve, and then you cross over the nose to the other optic nerve, 1,000 thoughts have gone through your head, and you can't remember what was the cup or the size of the optic nerve of the first eye. So we need to see these two together, and that's why you can put these two together and see that the cup to disc asymmetry in this case is because of disc size asymmetry. And no wonder the nerve fiber layer is going to be normal and symmetrical in both eyes. Now, there is another area that I've been looking at in glaucoma since 1995, and that is the macula. So why should we be interested in macula? Because glaucoma is a disease of the macula. And most people chided me when I said that. And they said, no, it's not a retinal disease. It is. The ganglion cells sit in the retina, and the ganglion cell losses are in the axons, which is seen in the cupping. And this layer is multi-layered in the macula and constitutes about 40% of the entire thickness of the retina. So if you look at the total retinal thickness as a surrogate measure, you can find out if there are losses due to glaucoma, because there are very few conditions that have losses of the retinal thickness. Vascular is one, optic atrophy is another, and the third is glaucoma, which is another kind of optic atrophy. The majority of the ganglion cells reside in the 30 degrees of the macula. 50% of all, because evolutionarily it is preserved. We can, keep the lights on in the auditorium, because otherwise I can't see whom I'm talking to. So, and they fall asleep very fast, so yeah. The percentage of ganglion cell loss that one needs to develop a visual field defect near the center is about 70%, compared to only 44% loss in the periphery. So there is a lot of redundancy of the ganglion cells around the fovea. Now, at that time, this was before the advent of the OCT. We created an instrument called the retinal thickness analyzer, because no one knew what the retinal thickness was. It was actually unknown. So therefore, we created the real normal retinal thickness. Now it's like, what? You didn't know what the retinal thickness was? No, it was never imaged in a live human being. And then we found that in contrast to normals, there was significant losses in glaucoma, and the losses were greatest furthest away from the disc, because the ganglion cell losses were there. When spectral domain OCT came, nobody was interested in the macula in glaucoma, and therefore there was no normative database. We took advantage of the fact that everything in nature is symmetrical. Actually, beauty is another word for symmetry. So, any retinal thickness will also be symmetrical, and therefore any asymmetry will be easily detected by the eye. So we created an asymmetry display. Sorry, this thing doesn't seem to stay, but I'll show you later. There is an asymmetry display subtracting one eye from the other eye and showing you the difference. For example, take a look at this one. This is a glaucoma suspect. This asymmetry display showing you that these boxes are 30 microns thinner in the right eye compared to the left eye. You can actually see it, but it is so much easier for this asymmetry display to show it to you. And if you look at the 3D reconstruction, which you can easily do with a Heidelberg machine, you can see this gutter, this groove of nerve fiber layer thickness loss, into which this blood vessel is dipping in and coming out. You can see the pinch here in the nerve fiber layer. You can see the loss. You can see the blood vessel dipping in and coming out. This clinical skill, where you can see and identify nerve fiber layer defects because the blood vessel that crosses it dips in and comes out, is a skill that is very valuable on the day your OCT machine does not work. Because then all your clinical skills come into play. You have to look at the nerve, you have to look at the nerve fiber layer, and you have to make a decision about glaucoma. So, just to put it all together, you can see the loss in the nerve fiber layer. You can see it compared to the normative database. You can see the loss here in the macular thickness, corresponding a small paracentral loss. Look at the difference or the discrepancy between the amount of loss on the visual field and the amount of loss on the OCT. There is a normative database now that compares the nerve fiber layer and the ganglion cells to normal. Let's look at the most interesting thing, artifacts and masqueraders. That is, any imaging device that we use, be it MRI, CT scan, anything, the machine will have artifacts, and it is up to us to identify those artifacts. So for example, this is a optic nerve that shows complete loss of nerve fiber layer, and I asked the technician to repeat the scan, and sure enough, in 2 minutes later, there is complete normality of the nerve fiber layer. How can this happen? This happens because the technician was not paying attention. They put the image on top, which got cut off. If they bring the image down, it gets normal. Now the question is, you have to identify how was I able to tell that that was an artifact? One, okay, it doesn't want to go back. One is that the nerve fiber layer thickness never drops down to 0. So if you see a nerve fiber layer thickness down to 0, it is an artifact. It always drops down to around 30 at the least. Second, the cup did not look extremely cupped, so therefore I knew that this was not a loss. Vitreous. Posterior vitreous detachment is the commonest cause of artifact. You can see here how the vitreous is attached to the nerve fiber layer and is tugging on it and is causing the nerve fiber layer to thicken. So when vitreous detachment occurs, this nerve fiber layer is going to look like it got thinner and it progressed, and it looks like glaucoma progression. Because I still haven't understood the role of the vitreous. It's only there to create mischief, right? Causes tears, detachments, messes up the OCT. And I don't know why they decided, when they did decide how to look at the nerve fiber layer, as to put a circle scan just in the same area where the vitreous is attached. The 3.4 millimeter scan is the exact diameter of the Weiss ring. Let's look at myopia. In moderate to high myopia, you get severe peripapillary atrophy. So one is we can decenter the scan to get a good nerve fiber layer thickness. And though this is not going to be reliable, and therefore neither is this, what you can see is you can see the nerve fiber layer thickness here and here is completely normal. If this thickness is completely normal, there is no glaucoma. You can actually visually see that, because glaucoma first affects these areas. This is getting confused because of peripapillary atrophy. You'll probably recognize this journal in which this paper has been published. This is one thing that highlights the importance of these rules for glaucoma diagnosis. When you see complete symmetry, you can see the macular thickness is very symmetrical. The nerve fiber layer thickness is also very symmetrical. And the field defects are also very symmetrical. You must realize that this may not be glaucoma. And this is segmental disc hypoplasia. This poor girl at age 22 was being treated with 4 glaucoma drops because it was assumed that it was glaucoma. On the other hand, when you get extreme asymmetry, like in this case, you see the severe loss of nerve fiber layer, there is no symmetry whatsoever. When you see this, you realize that there is a loss in the nasal region and a loss in the temporal region. And the reason, hemianopia. And you can see that on the macular thickness. You can see how the macular thickness is cut off vertically. You can identify this. Now, how we play a role with neurosurgery. When we see, can we stop the auto advance if there is one you're doing? Yeah. But let's go back. whenever we see the macular thickness and nerve fiber layer thickness, and somebody says bitemporal loss, we know that this tumor is not a fast-growing tumor because there is tissue loss and the patient is still there alive in front of us. So that is one. On the other hand, you see a bitemporal hemianopia, but you don't see any tissue loss. That is a fast-growing tumor because that has already done compression but hasn't yet caused the loss or the atrophy of the tissues. So those patients need urgent neurosurgery. So let's look at this one. There is no symmetry whatsoever, but the macular thickness loss is furthest away from the optic nerve. This turns out to be cancer-associated retinopathy. You can see the loss of the rods. The rods are lost, and that's why there is loss of nerve fiber layer and ganglion cells. This case highlights another rule for glaucoma. This looks like glaucoma, right? There is a field defect, there is a loss of nerve fiber layer, there's a loss of macular thickness, but it's not, because you see the temporal losses. In early to moderate glaucoma, you don't lose temporal nerve fiber layer thickness. Whenever you see temporal nerve fiber layer thickness loss, think neurological. There is something neurologic going on. And this turned out to be neurosyphilis, active neurosyphilis. And we were able to treat this patient and get this patient cured. If you see a vertical cutoff, a horizontal cutoff like this, where this part is abnormal, this is completely normal, same for the macula, then it is a vascular event, NAION. And then there are certain parts of the OCT, like I showed you, that you should pay attention to. For example, this is a 42-year-old patient who's on maximum medications, is coming here to me for a second opinion because somebody has recommended trabeculectomy. He's been diagnosed with normal tension glaucoma. You can see he's got almost no nerve fiber layer thickness. He's got very thin macular thickness. But his visual field is normal. How can that be? That means this is probably not glaucoma. But what is it? Are you able to tell what is it? This SLO image actually is able to tell you what the answer is. And the answer is, again, disc hypoplasia or morning glory syndrome. You look at these blood vessels, they're coming out of the disc like the spokes of a wheel. This only happens in this condition, disc hypoplasia. So when you see this, you should be able to identify that this is disc hypoplasia, this is not glaucoma. Now, glaucoma progression. It will be lovely, a great dream for all glaucoma specialists to retire their visual field machines and just manage patients with objective tests like OCT. So we have to be sure that the changes on OCT are due to glaucoma. How do I use OCT for glaucoma progression? First, I use the nerve fiber layer. You can see how this thickness is getting thinner in the yellow arrow. And then you can see where it is thinning. You can see the pink area. You can also see the macular thickness loss in an arc. This is the baseline from which this is subtracted, and what you see is these two arcs. The difference between these two visits is only 5 months. So in 5 months, you are able to detect great amount of progression. You can also look at these values if you want, and a value difference of more than 10 microns is considered possibly significant. Let's look at this patient, false progression. You can see that there is progression. There is pink that shows you that there is thinning happening over time. There is a negative slope. But that change is due to posterior vitreous detachment. And no wonder the macular thickness will not show you any change. There is a patient who continues to progress despite everything that I do, and this is glaucoma. As you very well know, I saw in the clinics yesterday very advanced cases and very tough cases. And you can see how this patient has been progressing over time with the losses of the nerve fiber layer and macular thickness. You can see it on the progression graph. But what's the anomaly here? The anomaly is this. How did the patient regrow their nerve fiber layer? How did the nerve fiber layer become thick again? Yeah, you can see it. It's real. It's real. You can see the nerve fiber layer became thicker. How is that possible? Anybody? You can see actually it grew. The reason is, the answer is here. It's a disc hemorrhage. Disc hemorrhages occur in the nerve fiber layer. So therefore, whenever a disc hemorrhage occurs, the nerve fiber layer thickens. And therefore, it looks like as if the patient regrew their nerve fiber layer. This is an example of an eye that had both false progression and masking of progression. What you can see here, you can see this red arrow showing you that the epiretinal membrane got lifted off, and therefore the nerve fiber layer became thinner. So it is a false progression. Whereas here, you can see the thickness actually decrease, but the graph did not show any real change. And this is how I learned to cure glaucoma in my pastime. You see, this patient came in 2010 without hardly any nerve fiber layer. In 2012, this patient has all their nerve fiber layer back. Is it possible? Yes, it is possible. And that is because nerve fiber layer thickens in uveitis. So any inflammation, whether it is post-op, up to 6 months after any surgery, you will see nerve fiber layer swelling. In fact, the uveitis division of our department has started using nerve fiber layer thickness as a most sensitive measure of activity of uveitis. And this is what we published in previously, that you see this nerve fiber layer that looks normal, cup that looks small. With the treatment of the uveitis, you can see how the nerve fiber layer thins. Unfortunately, the blame goes on the prednisolone or the steroid. Oh, it must be causing IOP spikes. That's why the nerve fiber layer is thinning. But actually, the steroid is actually treating the uveitis, and therefore the swelling is going down. Mind you, it's not only seen on the OCT, it's also seen in the cup. The cup also becomes bigger. So it looks exactly like glaucoma. And this is what I called high-risk real progression. When you see progression in the upper part of the nerve fiber layer, in the upper part near the fovea, it will translate to an inferior paracentral loss on the visual field. And it is that inferior paracentral loss that is the critical part of our vision. If we lose that, we lose our ability to read. Any other part of the visual field we lose, it doesn't really affect us until its end stage. Now, this is just another example of a segmentation error. You can see the loss here, but it is due to a segmentation error. And this example I put because Gorka asked me to add it in. And this is an example of a patient who came in having continued loss of vision, diagnosed with normal tension glaucoma, severe loss of nerve fiber layer, severe loss of macular thickness. But the diagnosis is a spot diagnosis. Anybody? Except Gorka. Vitamin A, exactly. This is a beto spot. This is an 80-year-old white lady who had Crohn's disease, because of which she had undergone hemicolectomy and resection of the bowel. And therefore, she was getting vitamin A deficiency. And what you see here is the reversal of the macular thickness loss. All those photoreceptors that had died or didn't really die, they were just stagnant, started waking up and the thickness returned. Last couple of points. When I was getting trained in glaucoma, we were trained to look at the disc. We were trained to look at the slope of the disc, the cupping, the shape, the bayoneting, the vessels. But then later on, we learned, look at a bigger picture, right? Look at the nerve fiber layer losses. But what I did not realize until just 18 months ago was that what I have been looking at as glaucoma and glaucoma progression may not even be glaucoma. Localized nerve fiber layer defects are useful for the grading of arterial hypertension. Especially if these defects are multiple, it is usually associated with systemic risk factors such as hypertension rather than glaucoma. Severe hypertension causes loss of the thickness of the nerve fiber layer and the macula over time. This is all in the hypertension literature. It's hardly in ophthalmic literature. They are wanting to monitor those diseases using OCT. The OCT measurement of the same areas that we look at for glaucoma, nerve fiber layer and ganglion cell thickness. And mind you, most patients with primary open-angle glaucoma have high blood pressure. And they also have cerebral small vessel disease. And they also have compromised kidney function. They are all associated with slow, progressive loss of the nerve fiber layer and the ganglion cell layer. This made me go into severe depression. Because now my technique of using objective methods of progression suddenly was thrown out of the window. The problem was that even the visual field losses are caused by these changes. So now I can't even rely on visual field. So what was I seeing? Was I really treating glaucoma progression? Because a patient came with a pressure of 19 and they had progression. Well, is that glaucoma or not? So I am telling you that all RNFL losses are not glaucoma, and progressive losses are not always glaucoma. So for the last 1.5 years, I've been scratching my head and trying to find out what is the feature in the OCT that you can find that allows you to identify it is coming from glaucoma or is it coming from a vascular disease. This is the exam that showed me. You see here a new field defect, new macular thickness loss, new RNFL loss. But 6 months prior, I've looked at the optos photo of this patient, and by chance, I picked up a large cotton wool spot. So cotton wool spots are only the tip of the iceberg. We see them rarely, only if it's large. I looked at the last 100 patients of mine. I found at least 10 eyes with small cotton wool spots that were completely missed on clinical exam. They're small enlargements of the nerve fiber layer, which I used to ignore. So why am I calling it the tip of the iceberg? Because that is only superficial ischemia. The biggest problem is middle layer ischemia. This is middle layer ischemia that I'll show you. You see this nerve fiber layer loss? You see this? This is middle layer ischemia. The publication is just going out. That paper is just going out. But what you can see is that there is a loss, and the loss is in the inner nuclear layer. That is the differentiating factor between glaucoma and vascular. Glaucoma is caused by the loss in the nerve, and therefore loss of nerve fiber layer, and therefore loss of ganglion cells, and therefore loss of inner plexiform layer. It stops there. Vascular because the entire upper half of the retina, including the inner nuclear layer, is fed by the same blood vessels, it is retrograde. So any loss of the inner nuclear layer is a vascular event. How do you identify? Am I going to sit and look at all of these images of all my patients? No, it's very easy. Look, you scroll through the retinal scans and you can see all these wavy things. I used to ignore them. I didn't know what they were coming from. Now I know this is all middle layer ischemia. Well, when I looked back at the last 100 patients, the patients who had this level of middle layer ischemia had already passed away, because it is actually a reflection of the entire body's small blood vessel disease. Many of them had passed away. So you can actually diagnose systemic conditions from looking at this. And then this is glaucomatous ischemic optic neuropathy. This is just to show you how the disc can get pale because of high blood pressure and high pressure spikes. And I think I'm past time, but I'll just share with you other aspects of OCT. This is the anterior segment. Am I past time? Or do? No, you're okay. Okay. I thought I had spoken for too long. So let's go back to glaucomatous ischemic optic neuropathy, GION. This is what I call GION. Patients who get a massive pressure spike undetected because they got chronic angle closure glaucoma. So they sit around pressure of 30 and then occasionally go up to 50, come back to 30. They have no symptoms. If they have high blood pressure, they infarct their posterior ciliary arteries. And that causes both cupping and pallor. And what you can see is that this BMO MRW, or the Brooks membrane opening that allows you to measure cupping, actually is completely normal, whereas the nerve fiber layer is significantly decreased. That means the nerve fiber layer has infarcted, but the cupping is not there because the glial cells are not lost. Loss of glial cells in the nerve is the hallmark of glaucoma because it causes cupping. In all other vascular events, the glial cells don't disappear. They die, but they don't disappear. So if you see the Brooks membrane opening is normal, that means the cupping is small, but the nerve fiber layer is lost, this is not a neurological disease. This is from vascular events that happen with glaucoma. Because I used to send these patients to neuro-ophthalmology. They used to get bored. They would send the patient back because they would find nothing. Then I would send to retina. They would get even more upset because they would find nothing. And then I realized this is something else. This is not a neurologic or retinal condition. Let's talk about anterior segment, OCT. This is something which we created for the first time ever in the year, as you can see, 2008. Anterior segment OCT. Schlemm's canal was never seen before. No one had seen the Schlemm's canal or the trabecular meshwork. We created a swept source OCT in 2006. And with that, we imaged. You can see Schlemm's canal, the green arrow. You can see the yellow arrow pointing to the trabecular meshwork. You can see the scleral spur. And the detail that you can see is almost similar to light microscopy, histology. So it is very useful in certain conditions, like identifying what kind of mechanism is there for angle closure. Now, angle closure is just another full talk that I can give you later, anytime, if you need. But here is an example of where the Schlemm's canal is, where you can see the yellow arrow pointing. You can see this mechanism is pupillary block, because you can see the elevation of the iris with the aqueous elevating it. This is phacomorphic. You can see the iris is just sitting on the lens. And you can imagine if you were to dilate this patient, how this iris and the trabecular meshwork would be in contact. And Dr. Edward and I were commiserating yesterday because we still don't understand narrow angle glaucoma. Why is it that some irides touch the trabecular meshwork and don't become sticky? And why is it that some touch and become sticky and cause synechia and cause glaucoma? We still don't understand that. So in conclusion, decrease of the global nerve fiber layer is not specific to glaucoma. The most common cause of decrease of global nerve fiber layer is posterior vitreous separation. Focus on the supero and inferotemporal sectors, and artifacts are present in over 1/3 of the scans. So, yes, your machine can give you fake news. Use your brain. I will share a couple more slides with you. Only I put them in because I thought maybe if there is time I'll share. And that is because somebody asked for it yesterday in our discussions. And that is multicolor imaging. This is a technique that is present in most of your Heidelberg machines. You just have to press the button and you can get such excellent pictures. These details are as good as seeing the actual nerve fiber layer. You can actually see it in such exquisite detail. So then if there is any loss, you can actually pick it up. For example, here is a child who has come with a very large nerve and a very large cup. OCT is inconclusive. But if I look at the multicolor, I can see that the nerve fiber layer is completely intact. And therefore, this child does not have glaucoma. Whereas this patient, you can see the nerve fiber layer defects here, here, very subtle ones. And you can pick up these nerve fiber layer defects. So with that, I'd like to end and be happy to answer any questions.
Thank you. Thank you so much, Professor Hani. Is there any questions? Comments?
This is your opportunity to pick my brain. And as you can see, I have been confused by OCT quite a bit. So I wouldn't expect everyone else to know everything about OCT either. Yes.
I have a question.
Yes.
Regarding the OCT and to detect the glaucoma progression in the event of an AMD, age-related macular degeneration.
Yes.
Any recommendation to like how to tell if it's progressing or not?
Yes, a very good question. Any macular pathology, such as age-related macular degeneration, will cause a loss of tissue thickness or increase of tissue thickness in the center. And usually glaucoma affects the sides of the center. So we just ignore the foveal area and just look at the perifoveal area and the supero and inferotemporal regions. So that is one place you can look at. What happens is if you got advanced glaucoma, where there is almost no nerve fiber layer superior and inferiorly, and you got macular, then your OCT is not very useful. Yeah. And there's a question at the back. Yes, sir. Correct. Very good question. Very good question. How do we apply it? How am I applying it to African Americans? How am I applying it to Asians? Unfortunately, the OCT normative database requirement for race-based thickness is a FDA mandated artifact. Race does not play a role in OCT thickness. It is refractive error that plays a role in OCT thickness. Whatever race you come across, Hispanic, I have all races. The place where I practice, I have all races. There is no difference. The only correlation is refractive error. The problem is somebody has inserted a bug in the FDA people's head that it is race related. And therefore, every machine is now required to get a race-based normative database. which is a total waste of resources. It would be lovely if there could be high myope, high hyperope thicknesses, and now high myope normative database are coming out. The other issue which has gone into people's heads is that nerve fiber layer thickness decreases over time, decreases with age. You know, it is commonly believed that the thickness loss, if it is greater than what is age-related loss, is considered glaucoma. And there is a loss of at least 10 microns for every 5 years. So there should be a loss of at least 15 microns in 15 years, right? No one has ever done the study. All studies are cross-sectional. The longitudinal studies are only 3 years. In 3 years, you can't make out. All that you're seeing is artifacts. It's just inter-measurement variability. We have just finished looking at the last 80 patients who have been followed for 15 years, from 2010 to 2025. Whatever age, there is no change. Patients who are 70 now are 90. There is no change in the nerve fiber layer thickness. So again, there is a myth that loss of nerve fiber layer thickness takes place with age. So if you just look at the data, you realize that no one has actually done the study. Yeah.
You had a question? Then I will let Dr. Malik first.
Sure.
So one of the biggest masqueraders to me is high myopia and myopic degeneration, and both in terms of OCT, disc appearance, and visual field.
Yes.
And of course, glaucoma is a progressive optic neuropathy, but myopia can be progressive as well. So do you have any tip for us as far as that's concerned?
Yes, absolutely. Actually, I wrote an editorial in JAMA Ophthalmology last year on which OCT parameter, if any, allows us to monitor glaucoma in myopia. And that is basically the fact that you can see, as I showed you in that myope, you can see the nerve fiber layer thickness in the supero and inferotemporal region, even if it is shifted towards the temporal region, because all the bundles of high myopes are shifted towards the fovea. So the normative database is going to come out wrong. So you have to completely ignore that and actually look at the thicknesses supero and inferotemporally. The second clue that I will give you is to look at it with a green light at the slit lamp with a 78 diopter lens, and or get a multicolor. And you can see the nerve fiber layer. And you can look at that thickness and see if defects are developing. But you're absolutely right. In patients who got staphylomas, high myopia, like -10, OCT is virtually useless in those cases where it's just not getting the scan. And you have to also remember to do the scans. If the patient is wearing a contact lens, leave the contact lens in. You'll get a better scan. And remind the patient to keep the contact lenses in every time they get the scan. Because if you get it once without the contact lens and once with the contact lens, it'll look like progression. So, but some of these are the tricks. And the biggest advantage, if they don't have central degeneration in myopia, is to look at that donut. That donut, if it is intact, there is a good chance that even if there is glaucoma, it's mild to moderate. It's not severe.
My is more than a question, is a comment. You know, I'm amazed by your talk.
Oh, thank you.
Yes, and I hope all my residents and fellow here were able to think while you were giving that beautiful lecture. We have a lot of Heidelberg here. We don't use it. They are parked. We even have an anterior Heidelberg parked in the glaucoma division there. We don't know the beauty that we have. I think that we should get you this week to put up those machines to work. And if you don't mind, I will request maybe short lecture for the technicians to understand that this machine, as you explained me early today, can work even faster, because one of the things they told me, oh, it takes too much time in our Saudi patient. I think that probably, and you can tell us how, we could do that adjustment in order to take faster scanners.
Yes.
Thank you very much
My
for this wonderful lecture.
Thank you. Thank you for all your attention and for coming. I'll be here for another few days, so feel free to pick my brain for any of these topics. Or if you have any ideas about how to look at things or any questions. Just yesterday in my discussions with the attendings whose clinics I was in, we came up with 2 new research projects that we could easily do. So there is a potential for a lot of cross collaboration, and I'd love to be part of it. Thank you.